Good evening, everyone. I welcome you again to a new episode of 4D 2.0, that is detailed discussion in diabetes and its complication. Today, we'll be talking about prevalence of diabetes and CVD, a twin epidemic I believe our country is facing today. And for this, we have a very eminent speaker today. I welcome Dr. Anil Mota.
Thank you, Doctor.
Good evening, sir. Good evening. Welcome, sir, on this platform. It's a pleasure for us that you are here for today's deliberation. Uh, Sir is currently practicing as a senior consultant in internal medicine and unit head at Max Super Specialty Hospital in Delhi. He has vast experience of more than 30 years in field of diabetes, preventive cardiology, and clinical neurology. He has done multiple publications in various research journals, and he has been a well-known faculty in various teaching programs like PHFI, Dr. Mohan's Diabetes Education Academy, as well as College of Critical Care. We welcome you, sir, and over to you, sir, for today's deliberation.
Thank you. I have a short presentation with permission, Dr. Atul. So I will share my screen. The cardiovascular prevalence in India, as seen by the Global Burden Diabetes Disease, it was recorded to be an estimated around 420 million prevalent cases of cardiovascular Asian region, which includes India. And as of 2017, cardiovascular disease was responsible for around 26% of the total deaths, around 13% of total disability regarding the adjusted life years in India. And the prevalence of coronary heart disease in India is around 21% for diabetics and less than half, that is around 11% for non-diabetics. The prevalence of coronary artery disease in the rural parts of the country is nearly half than that of the urban population of India. And as of now, acute coronary syndrome, ST elevation MI are the main reasons for the cardiovascular disease. But we have got hypertensive heart disease and the rheumatic heart disease, which are not uncommon. So we have acute coronary syndromes, disease, and rheumatic heart disease. So there's a big burden of cardiovascular disease in India. Now, the question is, why is cardiovascular epidemic in India a matter of religion? See, two things are important. There is a state level disease burden that has been reported to be around 2.5 times regarding the prevalence of both stroke. This was from 1990 to 2016, 20 years. And the study also reported that there was double in the number of cases of coronary disease, cardiovascular disease from 25 million in 1990 to 54 million in 2016. A report of the Economic Forum and the House estimated that India suffering losses between 2012 and 2030 around 2.1 trillion US dollars. And a study from Kerala indicated that the health expenditure across continues to be the highest. Why? Especially because we in India lack health insurance. So we come to the next. So we have to know the risk factors for developing of cardiovascular. So first, let me talk about what was in the previous slide. See, we have got a lot of worry regarding the risk for cardiovascular disease. First would be our genetic. Second, the urbanization of our lifestyles, the physical incapacity in we don't have a good lifestyle. We have gone towards junk food. We follow sedentary habits, and more importantly is that the more urbanization in money that we get, we lack in spending towards health. In fact, invest more in spending on issues that will cause us more obese, more dyslipidemic, or hypertensive. So the cocktail is that we have got more cardiovascular disease. And to top it all, we have got a lot of stress factors that have to increase manifold. Coming to diabetes prevalence in India, see, we had ICMR India study, which is the latest, and I'll quote from that because done at least in 30 centers, and it shows that we have, as of today, around 100 diabetes and around 136 million pre-diabetes, around the same. We have got around 250 million obese people Then we also have got people having central adiposity or central obesity, around 350 million. This, as of today, is a huge burden of 100 million diabetics and 130 million pre-diabetics and around 230 million dysglycemics. So you can understand the epidemic proportions of diabetes in India. And around 1 million deaths related to diabetes have been expectedly reported in 2019. So the burden of diabetes in India shows that in India, as we are talking about the incidence, vis-a-vis the world, vis-a-vis Southeast Asia, India has around an incidence of around 10%. This is expected to rise by at least, and across whole of India, the disease burden has been estimated by the average life years in 2016 was 440, have risen from 1990, where we were at the 35th place with diabetes, and now in 2016 came to the 13th place. So that is how much amount of diabetes is corroborating, contributing to non-communicable disease in India. Now, what are the risk factors for type 2 diabetes? Indian diabetics have some special peculiarities. Number one, first is our ethnicity. Asians have more diabetes because of a thrifty genotype. Second, many of us have a family history of diabetes, and we know diabetes and BMI about 23 in India is great. When we have gone to an inactive lifestyle, following sedentary couch potato habits. We are having more instances of hypertension. Again, that was proven by the ICMR study. We have got more dyslipidemia, especially atherogenic dyslipidemia. Then more incidence of PCOD and gestational diabetes, and more people above the age of 40 get diabetes early. And then we are more prone to pre-diabetes. So there are a lot of risk factors for type 2 diabetes. Now, what are the strategies for preventing diabetes and cardiovascular? The strategies are very simple. Number one, we have to change our dietary habits. Simple is, please go to the farm. Farm products means full grain, non-refined food. Third, whole fruits, whole vegetables, rather than refined food and junk food. Less of saturated fats. So that is the dietary change, and avoiding free sugar. So first is dietary change. I'm talking of the we are talking of the modifiable factors. See, we cannot change our parents, we cannot change our ethnicity. They are non-modifiable factors. On the other hand, modifiable factors are to do with our diet or nutrition. Third is to reduce free sugars and carbs. Follow an active lifestyle of at least a 200 to 300 minute walk, which is a structured walk program, program per week. Taking medications for our diabetes, hypertension, and any comorbidity, and most importantly, monitoring our weight. So we have to change our diet, we have to change our lifestyle, we have to take the medication on time, we have to monitor ourselves, and then we will avoid complications. Now, coming to what are the therapeutic strategies are more to do with the medications. A diabetic in India is prone to at least a comorbid condition of hypertension, dyslipidemia, and at a more risk for getting, kidney disease, peripheral neuropathy, vascular disease, micro as well as microangiopathy. So our diabetic, addressment of hyperglycemia should not be only to control glycemic status. So we need medications that number one will improve the preservation of beta cell function, and second, it has been shown by multiple studies that in Indian patients the combination therapies do well. On top of metformin, we do well with both DPP4 inhibitors as well as SGLT2 inhibitors. So Asians do better than Westerners and Caucasians. So newer medications we have is the gliptins, both the SGLT2 inhibitors and the GLP-1 receptor analog. So if I initiate a combination therapy, that will help me number one in controlling sugars early, but more importantly by having addressing multiple parts of the pathophysiology leading to diabetes. So we have to initiate combination therapy so that we are able to control sugars, means glucocentric approach. We are able to have a time in range sugar. We have to give cardio, renal, metabolic benefit to the patient. So if I give a combination of an SGLT2 inhibitor with a DPP4 inhibitor like dapagliflozin and sitagliptin, potent drug that will cause hypoglycemia. Number two, DAPA and SITA are both tolerated better and have a better therapeutic response in Asians. And more importantly, is we are able to give them a better metabolic legacy and a cardio-metabolic protection. So the combination helps in achieving the target with a better and more importantly, giving a better metabolic legacy to the patient. So that is the therapeutic strategy. So what does the combination therapy do? Number one, if I use an SGLT2 with a DP4 inhibitor, increase glucose, urinary output in glycosuria. It will improve beta cell function. It will also have a good glucagon response. A DP4 inhibitor improves the inherent GLP-1 that the patient is having. So we are acting through synergistic combination mechanisms that will reduce sugars, at the same time reduce weight, at the same time reduce systolic blood pressure by at least 5 millimeters and not cause weight gain. So we have got glycosuria, we have got beta cell preservation, we have got reduction of weight, reduction of systolic blood pressure, and they have got a complementary effect as anti-inflammatory drugs. So the recommendation came from all algorithms that you must you will do well in patients if you combine a DIP4 inhibitor with an SGLT2 inhibitor because you are giving cardio renal metabolic measure. They are indicated in atherosclerotic heart disease. They have got reduction of microalbuminuria and at the same time a beta cell preservation. Lastly, SGLT2 inhibitors also prevent the risk for hospitalizations for heart failure. So we in a combination therapy are using a multiple ways of addressing the pathophysiology of diabetes with cardio, renal, metabolic protection. By nutshell, I want to say that diabetic Indians are more prone to cardiovascular disease at a younger age. Number two, we do very well with combination therapy, and we must choose a combination that helps at acting on the multiple aspects and prevents both cardiovascular worsening and controlling glucose and keeping the man in time and range. So a combination of SGLT2 inhibitors with DP4 inhibitors will do the trick. So I hand it over back and would be very happy if I have to answer any questions. Thank you.
Thank you for a very detailed deliberation, and we have a few questions for you. So, according to you, how has urbanization and changing lifestyle contributed to increasing prevalence of CVD and diabetes in India?
Okay. See, we all know that in India, that diabetes is nearly twice as present in the urbans as compared to the rurals. A 2024 study said diabetes around 18% in the urbans and around 9% in rural. Same is true for about cardiovascular disease, that it is around 13% in the urbans and around 7% in the rurals maximum. A Vellore study said that in urban males it's around 7% and the rural males around 3%. So what does it mean? It means that urbanization is more associated with cardiovascular disease. And why so? There are four important aspects to that. Number one, urban has caused us to go more towards obesity. So we have more abdominal obesity. We eat more of junk diet. We have got physical inactivity. Though we have more access health care in the urbans, but we will take we will take our refined food, junks, and not go to the farm. our intake of salt goes up, our intake of saturated fat goes up, and our lifestyle becomes sedentary.
Yeah.
So
Thank you, sir.
that is
And
why both diabetes and coronary artery disease are more in urbans.
yeah, definitely. And sir, I believe that us forgetting our roots of practicing yoga and doing all those exercises have also contributed to increase prevalence of these diseases. I recently started doing yoga, and the first question that I asked myself was, why was I not taught this when I was 8 or 10 years of age? It's really wonderful, and I believe that is also one of the reasons of increased prevalence of these non-communicable diseases in us Indians. We have forgotten our roots, I believe. So
I remember
you
my
have talked.
professor, Professor Dash, who was considered father of endocrinology in PGI Chandigarh.
Yeah, yeah,
He always
yeah,
used to say that we have to tell each and every person whether they're diabetic or not that please
yeah.
use your legs more and your mouth less.
Definitely. Yeah, yeah, absolutely right, sir. That's absolutely right. If we start following that, it will prevent two problems. A will be having less fight with others, and will be keeping us ourselves healthy as well. Absolutely right, sir. Uh, so, any gender-specific trends that have been noticed in studies in the prevalence studies on various cardiovascular diseases as well as diabetes? Any gender, like it is more prevalent in females or more prevalent in men? Any gender-specific issues regarding prevalence?
Yes, you see, again, I'm quoting from the statistics that are available. Premenopausal females have got estrogen protectivity because estrogen helps in the insulin uptake by the microvasculature at the level of the muscle. So premenopausal females are less, but and on the contrary, the testosterone is more associated with insulin resistance. So the nutshell of the story is that in males versus females, what has been seen that after starvation, males are more prone to developing fasting sugars, higher fasting sugars in males, and females are not able to handle an OGTT, means they are not able to handle the sugars properly after a glucose load. So
Yeah,
females have more of abnormal glucose tolerance, but males have more of increased fasting sugar. Regarding cardiovascular disease, as per the Vellore study, females have more cardiovascular disease than males. That was both in rural as well as urban males and females. So the Vellore study said that females do more urban and rural. But diabetes, it is worse in males and less in females.
thank you, sir, for your insight on gender specific trends. So as we know that in India, it is that more than 90% of our patients pay out of their own pockets. So, what are the economic implications of such high prevalence of cardiovascular disease and diabetes, especially in India, in terms of healthcare costs?
See, I will, Dr. Abdul, tell you one very important thing. We are not comparing ourselves with Westerners. Why? Because here, most people are not backed up by insurance. So most of the people are paying from their pockets for their medical care. The STEPS survey, that was known as the STEPS survey, and that showed that in an OPD basis, a less than 20-year-old diabetic is spending around median of 50,000 rupees in India.
Yeah,
And between 20 to 40, the cost increases more because in addition to this 20,000 rupees, he has more indirect costs, which are including complication, treatment of other illnesses, hospitalization, and all that. So there are more of indirect costs. And more than 60 years of age, the cost is far more because there are both direct costs and indirect costs. And that includes higher risk for hospitalization. This was a STEP survey. In a general note, uncomplicated diabetes costs an Indian and a complicated diabetes costs him more than 30,000 rupees. And if the person is going to for a renal replacement, means a dialysis, that the cost rises by 7 times. So you
Yeah.
can understand the huge healthcare cost factor for an Indian diabetic.
Huge cost. Yeah. You rightly said that it's definitely a huge uh, healthcare cost for especially for Indian population because of the increasing prevalence of this twin epidemics, and like you are saying, it is mainly that is paying out of their own pockets, and it really adds to their worries whenever we are seeing a patient with chronic disease. uh, so now we have combination therapies like sitagliptin and dapagliflozin available for management of diabetes. As per you, how has it impacted the overall management and prognosis of patients with diabetes and concurrent cardiovascular diseases?
See, Dr. Atul, you have to understand two things. Number one, first, combinations will do much better, especially in reducing the pill burden. First. Second, combination of Sita and dapagliflozin is very important because it does not cause hypoglycemia. It has a cardio-renal outcome improvement, and it's an anti-inflammatory drug too for the diabetic with a cardiovascular disease. So, in all, it has got an effect on the cardio-metabolic continuum. So it goes beyond glucocentric approach.
Yes, sure. Combination of gliptin and dapagliflozin are complementary, and like you rightly said, that they help us to achieve beyond glycemic control. Not only they address the issue of glycemic control, but also there is now clear evidence that DAPA is associated with the reduction in all-cause mortality as well as cardiovascular mortality in patients with diabetes. So, just a last question: uh, where do you see this combination versus the traditional combinations that we used to use, like sulfonylurea and metformin, in terms of weight management, energy levels, and overall well-being of? Just a
Yes,
last,
this is very,
yeah.
very important because see, by giving the traditional by the traditional approach by which we use sulfonylurea, see, most of the algorithms and guidelines, they say that sulfonylureas have taken the lowest seat. It is because they will flog the of HbA1c by more than 1.2% and help in beta cell preservation. So I would, if you see what we got from the combination of Carolina trial, that giving just a diffuser into like linagliptin alone is giving a good glycemic efficacy, just like glimepiride. But on the other hand, as further studies came, the DAPO heart study, the DAPO kidney study, all this that showed that yes, we are giving much better protection on cardio, protection and blocking the metabolic worsening. That means the inflammatory worsening. So there is no doubt that they score far above the conventional treatment like metformin, glimepiride alone.
Thank you, sir. We absolutely agree with you. Uh, uh, just before signing off, last message from your side to our audience.
Dear, that we should learn from our past. The nutshell is please intervene and hit early, hit right, and hit hard. Aim is that we have to give the person a good and the earlier we do it within the first 2 years of the diagnosis, the better we are going to help him in metabolic control and preventing him from getting complications. So we should use combinations early in our patients, especially combinations that promote weight loss, don't cause hypoglycemia, reduce systolic blood pressure, and have got a good control on glucose and keep the person most of the time in range. That is my message.
Thank you, sir. It was a pleasure having you here on this show, and I hope our audience would have learned a lot from you today. Thank you, sir. Uh, uh, it was a great talk today from Dr. Anil, sir. And before we sign off, just our last few words. Prevalence of diabetes and CV disease is increasing, and probably it is a changing lifestyle that has made a huge impact on this. Going back to our roots and starting it early in the course of life. That is, we should teach our kids to be more active. They should play in the grounds more rather than playing on their phones and sticking in front of screens. They should be doing this less, and doing yoga and other exercises right from beginning may help in reducing the prevalence of this twin epidemic. And like sir was saying, that it will have a huge economic impact on Indian economy. This twin these twin non-communicable diseases will have a huge impact on Indian economy as well. So if we are able to prevent the development of these diseases, probably it will improve not only our patients' life but also Indian economy as well in that